Our speaker today is a native North Carolinian who is the 112th president of the National Medical Association. Dr. Cedric M. is a graduate of Brown University and the UNC Chapel Hill School of Medicine. He has served as a staff physician at the Veterans Administration Medical Center in Durham, Associate Clinical Professor of Internal Medicine and Community and Family Medicine at Duke University. He currently serves as Assistant Dean of Special Programs and Admissions at the UNC Chapel Hill School of Medicine in the Department of Medical Education. You will find additional information about him in your luncheon program. As I indicated earlier, he hails from Winston-Salem, North Carolina. Dr. Bright and his wife, Maria, reside in Durham and have one son, Andrew. The Alliance offers its sincerest condolences to his family in the recent passing of his mother, Mrs. Bessie Joyce Bright. So we are extremely honored to have him with us today. And so, ladies and gentlemen, I present to you Dr. Cedric M. Bright.
Good afternoon. Good afternoon. So while we are working on the technical component of this talk this afternoon, I just want to say it's an honor, it's a privilege to be here. I'm very grateful to have this opportunity to stand before you. I'm thankful to God for His grace. I'm thankful to God for His mercy, that He allowed my mother to travel home. And for that, I'm extremely grateful. My heart is heavy, but my soul is lifted up. What I plan to speak to you about today is the Affordable Care Act and how it is being implemented nationwide from a nationwide perspective, and then how it's been utilized here in the state of North Carolina, and then talk a little bit about some of the demographics within the state, within the nation that are going on that are really going to make a difference as we move forward into the future, and what those implications may be if we don't have the elimination of health disparities, or more importantly, move to health equity. Now, when I talk about health equity, I want you to understand that there's two ways that you can look at equity. Equity could be that everybody has the same health care types outcomes and they're all bad. That's one type. That's called a race to the bottom. What we want is a race to the top, where everybody has the best outcomes, has the best access, and has the ability to have the best health that they can possibly have for the longest amount of time. That's what we want to talk about here when we talk about health equity. Let me just give a disclosure to say that the statements that I'm making today are mine and mine only, and have no attributing to the University of North Carolina, so therefore I can speak freely. So the Affordable Care Act, to me, it's a law. It's amazing to me how many people keep thinking that it was not a law, that it was just some type of dream, that was a bad dream, and they want to keep trying to repeal it. But the fact of the matter is the Affordable Care Act is a law, and there's been over 40 attempts that have tried to repeal this. The purpose of well, let me just back up and say this. We always say the Affordable Care Act, and we miss probably the most important part of the act, and that was the two P's in the front: patient protection and the Affordable Care Act. The purpose was to protect the patient. Now, I'm a doctor. I see patients all the time. But you know, at some point in time in my life, I have to be a patient, and I have my own doctor that I go to. And it's nice to know that there are some protections in place that will help me with my insurance to ensure that I have the ability to see my doctor. It was a part of this reform, was reform of the insurance industry and reform of the medical payment. The focus of this program, the Patient Protection and Affordable Care Act, to me is a major paradigm shift in medicine. Because this program emphasizes preventive medicine. Preventive medicine. I like to remember it this way. The Affordable Care Act, or Obamacare, as some folks call it, I like to call it Obama Cares, because he cared enough for people to give them patient protections, right? He would prefer that you stay healthy longer rather than get well soon. That's what we mean when we say a paradigm shift. We're shifting from when somebody gets a disease, now we access the healthcare system. And then we have all these costs that we have that occur after that, to where we have a healthcare system where we keep people healthier longer and they never incur those costs. That's what the focus is. It has provisions that will allow collaboration with both the public and the private sector. This was not a government takeover. I'll say it again. This was not a government takeover, but rather a collaboration that could occur potentially between both the public and the private sector. The goal was to decrease costs by decreasing redundancy, decreasing errors, decreasing fraud, and most of that was to occur by expanding health information technology. Another aspect of this was that it would also help to grow a diverse healthcare team by promoting and funding for mid-level providers to help meet the need. Because the honest truth is, there is no instant doctor. You don't take a cup of water, add a mix, stir it up, ooh, doctor. Most doctors take at least 7 years of training before they have the ability to come out and see a patient. 7 years. So if we have millions of people coming into our healthcare system and we don't have to take 7 years to get a doctor to become a doctor who can see patients, how are we going to meet the need of the demand of these people that are now getting access? Because the worst thing in the world is to have a credit card and have nowhere to shop. My wife will tell you that. So what we have done is to create more money toward mid-levels, because in 2 years we can produce a nurse practitioner. In 2 years we can produce a PA. Most of us who are healthy, hear me now, most of us who are healthy may not need a doctor because we're healthy. I know when I see my healthy patients, I'm happy. Because I go, hey, how you doing? How's family? How's everybody going? I don't even talk about medicine. I talk about everything else in their lives because they're healthy, okay? Nurse practitioners and PAs can perform that same task and have the same outcomes as a physician can. In fact, if we reorganize our healthcare system such that physicians took care of the sickest of our patients and allowed others to see the well patients, we would actually have enough providers. But that's not the way our system works, because that's not the way reimbursement is tied, but I have digressed. This program has also set up funding for Medicaid expansion in order to cover the poorest of the poor, the sick, the disabled, the underinsured, and most importantly, the working poor. How many of y'all know about the working poor? Can you raise your hand? Now, I'm glad that all of y'all know about the working poor, so I don't have to tell you, how many times does the working poor pay for something? 3 times. Every time they go to a doctor, they pay 3 times. Why? They got to pay a copay. Then if they get a medication, they got to pay for that medication, right? Then guess what? They miss work that day. They don't get paid for that. They had to pay. So therefore, that's why it's so important that we put in place things such as Medicaid expansion, which this state has denied 539,000 of its citizens. There is also more funding for programs such as safety net hospitals, safety net community centers. I had the privilege to be able to serve as the chair of the board at Lincoln Community Health Center, one place that Gene Lucas definitely loved, and I served for Sister Bernadette. And we had a great time on that board at Lincoln Community Health Center. And we did a lot of great things there. But guess what? It was busting at the seam. Folks were having a hard time getting in to be seen because we had such a long wait list of folks who wanted to get in. That's a reflection of our economy because at Lincoln, 80% of our patients that we saw were at or below the federally qualified poverty level. 80%. 26% of those were totally uninsured. Totally uninsured. If it wasn't for the 330 grant and in-kind services from pharmaceutical companies that allowed our pharmacy to have cheap drugs, or should I say, inexpensive drugs, Lincoln would not have been able to meet the need of its community. And therefore, safety nets like that and those fairly qualified lookalikes, community health centers that you may have in your county are very important because that is the access portal for folks who cannot find a private physician who will take their insurance. So, in refusing the provisions of the ACA, it has many implications. As I've already told you one, and that is 500,000 people in North Carolina have been left without an insurance option. Not because they make too much money, because they make too little money. When have we ever turned somebody away because they make too little money? What kind of criteria is that? To me, that's just, it is ungodly. If you have done it to the least of these, I also hear this statement when I was over at the General Assembly that, you know, one of the things they talked about is they didn't trust the government to fund the programs, right? And by rejecting this, you know how much money we are losing a day? In a day. This state is losing $5 million a day because we have rejected the expansion. $5 million a day. And not only are we losing that money, but we're still paying our taxes, and that money is going to other states who accept it. So there are going to be other states that are going to have better health outcomes in our own state from our own money. That's not making much sense to me. More importantly, some of you know who are in the smaller counties that some of your small hospitals are having to shut down. But they're shutting down because there's no expansion. So there's no further coverage for the uninsured. And when there's no coverage for that, there's no reimbursement. Those hospitals suffer. Because they used to be able to get an appropriation from the government called DISH, which was money that you received to help take care, to offset your costs for taking care of charity care of those who are uninsured. Well, when the Affordable Care Act became law, DISH was phased out because the idea was that if we gave everybody insurance, there would not be uninsured that we would need that payment for. By us rejecting it, we have put those small hospitals at risk. And it's not just the small hospitals. The big universities like mine in Carolina, that's a public institution, we're at risk. You know, hospitals only operate at a very small profit margin, believe it or not. Believe it or not. Most hospitals operate at about a 3% profit margin, 3%. Now what you're talking about with the loss of these payments, you're going to see hospitals going to be operating at a 1.5 or 1% profit margin. They're still making a profit, but when you talk about expansion of services, when you talk about increasing of service lines, where is that capital going to come from? It's not. So some of the arguments that I've heard against the Affordable Care Act, Patient Protection and Affordable Care Act. Number one, when I was at the General Assembly, the number one argument I heard was they did not trust the federal government to pay the money. Help me out, folks. When was the last time our federal government didn't pay something? That's why our debt keeps going up and up and up. Because instead of sometimes not paying a debt that we owe, we pay it. right? That was the number one thing. But you know what? I sat back and I thought about it, and one evening I had an epiphany. And the epiphany I had was this, that the people who were against this were saying this because they didn't trust their own colleagues in Washington to not try to steal all the money out of the Protection Act. They did not trust that they would allow the Congress and the Senate to actually appropriate the money. And if they can't appropriate it from Washington, then sure enough ain't gonna get here. That's what I had to figure out was what was going on, more so they didn't think the government was gonna pay, because the government always pays. Government always pays. The next argument I heard that has been on the television that's been just killing me. It's been killing me, folks. This whole thing about you can keep your insurance and you can keep your doctor. Ladies and gentlemen, many of us were walking around here with hospital gown insurance. You know what a hospital gown looks like, right? Okay? We covered in the front. Bottom line was that insurance that they had no more coverage than just the front of their body and didn't do nothing for their back. And that was why the Patient Protection and Affordable Care Act had minimal health benefits that had to be put in place to make sure that you had prescription coverage, to make sure that you had reproductive coverage, to make sure that women didn't have to pay more money just because they were women, to make sure that you had emergency care, to make sure that you even had mental health services. That's something most insurance companies don't even cover. Now, there are other options. We don't have the eye coverage, and when the National Medical Association and the National Dental Association actually fought that dental insurance should have been part of the minimal benefits. Because, ladies and gentlemen, I don't know whether you know it or not, but I believe the mouth is the portal to the rest of the body. If you have bad gingivitis, if you have bad periodontal disease, you have increased risk for cardiovascular disease, increased risk for stroke, you have increased risk for cancers, all because your teeth is bad. Bad language, I'm sorry. That wasn't real good English. But that's the bottom line. So if we're not protecting the teeth, then we already have put our bodies at risk. The next thing they talked about was it was a job killing bill. Job killing bill. Job killing bill. Okay, $5 million a day. How many jobs is that? Oh, let's go even more than that. Let's go $1.5 billion a year. How many jobs do you think we can get? We can get a couple jobs with that? We can get a lot of jobs with that. But unfortunately, we're not in this state. The other thing I keep hearing that just makes me almost want to cry, and that's our Medicaid system in this state is broke. That we need to refix our Medicaid system and privatize it all out. Come on, people. Our Medicaid system, Community Care of North Carolina, is nationally renowned as one of the most efficient systems for Medicaid coverage in the nation. In fact, let me just give you a number. Our spending on Medicaid in North Carolina since 2008 has decreased by 11%. 11%. On the national average, there has been an increase in spending for Medicaid at 6%. Now, I heard some talk today about ACOs and managed care, and yes, the honest truth is, I think it's oxymoronic that ACOs would come out of hospitals with the idea that they're going to have to ration care in order to asking a hospital to save money. Never known a hospital that want to save money. They want to make money, right? They want to do procedures. They want to be able to generate revenue. It makes more sense in the community setting when you have federally qualified health centers that have what we call just a stat budget. You get so much, it's kind of like a block grant. You get so much money, and that's all you got. And you got to make do with what you have, okay? That's where efficiency comes into play. I think that's more to people in private practice, people who are part of fairly qualified health centers, than I think it is to hospital systems. However, that being said, I have seen actions at the University of North Carolina within our own clinics to increase our efficiency, to decrease our redundancy, and to increase our outcomes. That's the triple aim. The triple aim that we have is to have better outcomes, better access, at decreased costs. One of the things that's an alternative to what we're getting in North Carolina, that could be an alternative that I hope might be considered in North Carolina, is being put forth in Utah by Governor Gary Herbert, who has asked the federal government to give them the money that they would have given for Medicaid expansion in a block grant and allow them to use that money to subsidize people who are at or below the 133% federal poverty level. That's one innovative idea to try to address what we're going to do. But the bottom line on that, though, still is that for those people who are making less than $11,500 a year, that's 133% of the federal poverty level, making less than that, they would have to still pay $420 a year out of their meager $11,500. So they're still going to ask in that area for folks to put skin in the game. And I understand skin in the game. That's a good thing. We all need to have that. But sometimes you can't get skin in the game when ain't no skin left. And that's what we have to understand, what is reasonable and what is right. Over 200,000 North Carolinians have already signed up for the expanded coverage through the Patient Protection and Affordable Care Act. These benefits and the benefits in the health exchanges are making us one of the leading southern states to have this. Interestingly enough, I just read an article that talked about how Southerners, although they hate Obamacare, they don't want it repealed, they want it fixed. They would much rather have it fixed than to have it taken away because they're already seeing the benefits of having it. The most interesting thing to me is that the people who are championing, are trying to repeal this, are cutting the nose off the face of their own constituents. They think they're hurting us, but the truth of the matter is there's more of them that need it than we. So the bottom line is, who are we hurting the most? You know, we can't continue to try to have a country that has misplaced values, and sorry about that, has values that only the top crust deserves to have the best things. We have to have a system that says that everybody is equal, that everybody has a right, that everybody should have a chance at the best health care as possible. So as I wrap up here today, I'm going to just talk to you a little bit about what I think that that you as elected officials and me as a leader in healthcare, we need to do. And I think it's an imperative that we understand some of the changing demographics in our state and in the nation and the cost of health and equity. North Carolina is no different than the rest of the nation, and that is becoming a browner state. This is due in part to population shifts from the North and from the Midwest. The South, in particular, is gaining population at a rate of 51%. 51%, while other parts geographically in the nation are losing population. That's important because that means our population is growing and we're going to have more and more people that are going to be trying to access the resources we have for healthcare. This growth is fueled by the migration of Hispanics and blacks and foreign-born and the elderly. In fact, 85% of the growth in the South is due to non-whites. 85% of the growth is due to non-whites. And why is that significant? Because in 2012, the number of minority first graders in the United States hit 51%. You catch what that means? That there are more minority students coming into the first grade now than there are majority. Which means, as we move forward, it's going to start changing that majority, right? Let me hit you with another fact. That the average age of women in the United States are diverse in how they come out. For instance, the average white woman in America is 43 years old. The average black woman in America is 34 years old. The average Hispanic woman, 22. Who's having babies? Who's gonna have those babies? I've heard of some 43-year-olds having them. But I heard of a lot more 22-year-olds having them. That's where the shift is coming from. We need to understand that. Not only are we becoming more of a diverse race, but we're becoming more of a heterogeneous race. Because more people are marrying outside of their race than ever. In fact, in 2010, 14.6% of marriages were between races, as compared to 6.7% in 1980. In fact, the greatest areas are between Hispanics and whites, Asian and white, black and white, and both non-white. So therefore, we're becoming a mixed society. To further compound this picture, we must also understand that America is becoming more gray every day, and that it is from our baby boomers like me, born in 1964. No, 63, I'm sorry, I'm a year older than that. And they're turning 65 at a rate of 8,000 a day. 8,000 a day, folks are turning 65. AARP is so happy. They enrolled. Right, yeah, see, I gave you a plug, you didn't even know it. This raises serious questions about our ability to do what? Transfer knowledge. Because if folks are retiring, who are they telling that knowledge to for all those years they've been in the workforce? We're going to have to develop effective mechanisms on how to exchange knowledge. Because otherwise, we're going to lose our competitive edge. The other aspect of that is, as these folks are turning over and the jobs are being vacated, and we have folks that are not being able to take over those jobs, that means we're going to have a decrease of our tax base. And if we have a decrease of our tax base, how are we going to pay all our seniors who have earned the right for their Social Security? How are we going to pay for them? Who's going to pay for them? In 2010, we have another trend that is going on. And believe it or not, it's called the end of men. The end of men. In 2010, women became 50% of our workforce. 50% of our workforce. And when we look at higher education in 2010, women received 572,000 more degrees than men. In fact, for every 2 men they graduated from college, 3 women did. So basically what's happening is now our population is shifting to being older, and we have more women in charge in our population. And during our recent economic turn down, you could actually say it was a man down, because what happened is men were more adversely affected than women. Women lost $1.7 million jobs during this economic turn down, while men lost 4.7 million jobs. What does that mean? That means that we've had an increase in the number of households that the women are the major breadwinner. In fact, 63% of women in 2008 were the major breadwinners or the co-breadwinners of their households, which was up from 27% in 1960s. To bring it more home in North Carolina, there are a few counties in which the growth rate is less than the death rate. You catch what I'm saying? Yes. There are more folks who are dying than there are folks being born. In fact, there are close to 30 counties in this state that are just that case. There are only about 6 counties in this state in which the growth rate is greater than the death rate. Raise your hand if you're from these. Mecklenburg, Forsyth, Guilford, Durham, Wake, and Johnson County. All the rest of y'all, your undertaker is getting nervous because he's trying to figure out who's going to bury him when he goes. So we have to stop and think, ladies and gentlemen, about where our population is going to come from to fill back in for all of these wonderful, corporations we're bringing in to raise our economy in North Carolina. Where is our workforce going to come from? We have to think about these as we move forward. And we also have to think about our education system. Senator McKissick spoke very eloquently, I thought, with regards to where we are with our education system. Understand this, ladies and gentlemen. If we're in a Browning society, and most of our Browning students are in the public school system, and the public school system is getting money taken from it every year because of budget cuts and budget constraints, where are these students going to get the education and the knowledge that they need in order to be competitive in a global society? You see, ladies and gentlemen, we are no longer can just bask in the beauty of not only our own state, but this United States of what we call America. If we are not competitive in a global market, we will be left behind. Even Rome had a decline and died. Because when you fill yourself up with so much heart, so much self-importance, that you think that everything here is so great and everybody else is second class, the whole world is looking at us and saying, y'all don't even know the true meaning of civil rights yet. You still have yet to let your captives free. And those are the captives that we are denying their education at this precise moment. So there is a collective that we must focus our energy as elected officials, as appointed leaders, and as business entrepreneurs. We must focus our efforts to ensure that our educational system is equipping the next generation to be technologically proficient, able to maximize technological advances for the common good. We need to ensure that our growing elder population can transfer their lessons that they've learned so we don't make the same mistakes in the future. As leaders, we must put the cares and concerns of those who appointed, anointed, or elected us to the forefront and not be bogged down by our own petty political infighting. The economy, the future of our state and of our nation will depend upon our next generation, so they must be properly educated and have the best preventive health care services in order to remain productive as a workforce. We must also never forget the lesson that in order to have a right, you must take on the responsibility. You can no more ask to have the right of freedom and not fight to protect that freedom. That is what our military does each and every day. And I thank our military, and I served at the Veterans Hospital for 13 years. And there was no greater job that I could have ever done than to serve a veteran who put his life on the line and her life on the line to protect our freedom. The ACA has made health care a right. almost accessible to all. The legislation is not perfect, but then again, nothing born of man is perfect. To me, the ACA is like a rising tide that lifts all boats. For those outside of the boat, though, those who lost the Medicaid due to non-expansion, that rising tide threatens to drown them. And it's up to us to reach out to those and to bring them into the boat. But people, we cannot get complacent. And as we see the shore on the horizon, feel like we're close enough to the shore that we can get out the boat. Because just as sure as you get out that boat, that water's gonna be deeper than you thought. We must finish the task. The victory doesn't go to those who are swift. It goes to those who endure to the end. We must be the ones who will shine the light. We must be the ones who shine the light on selfish interest. We must be the ones to not let selfish interest be the light that we shine, but more importantly, that we let the light that's from inside of us shine out to other people so that they will ask, what is it about you that makes you give of yourself so much? What is it that makes you so selfless? Selfless people don't think less of themselves, they just think more of other people. And that's the kind of people we want to be. So I'll end the talk with this wonderful statement, a frat brother of mine, Nelson Adams. I always used to end his talks at the National Medical Association with this quote from Benjamin E. Mays, a good frat brother as well. And yeah, I ain't gonna throw in the hood. But ladies and gentlemen, all that we do, and in all that we say, we must give our best. All right. I want you to remember it this way. Good, better, best. Never let it rest until your good becomes your better and your better becomes your best. Thank you so much. So glad you have me.